The next time someone over 65 in your family walks into a hospital for a routine procedure, there is a very good chance they will walk out owing money they were never supposed to owe. Not because something went wrong medically, because something went wrong administratively, quietly, on a piece of paper they never saw, in a system they were never warned about. Do not let them walk through those doors until you hear what I am about to tell you. Every year, millions of seniors enter hospitals trusting that the system is set up to take care of them. And in many ways it is. The doctors are skilled, the nurses are dedicated, but wrapped around that care is a billing and administrative infrastructure that operates on its own logic, a logic that does not always have the patient's best interest at the top of the list. And the people who get hurt most by that logic are the ones who never knew to push back. What I'm going to walk you through today are 5 specific traps, real ones, documented ones, ones that happen in hospitals across this country every single week. And for each trap, I am going to give you the exact words to say, not general advice, not vague tips, but actual sentences you can write down, memorize, or screenshot and carry with you. Because in a hospital, the difference between a $200 bill and a $20,000 bill often comes down to one sentence spoken at the right moment. Let us start with trap number 5. Over the last decade, something massive has shifted in American healthcare, and most patients have no idea it happened. Hospitals have been buying up independent doctors' offices at an extraordinary rate. That family physician you have been visiting for 15 years in that small brick building on the corner, the one with the familiar receptionist and the magazines from last year in the waiting area, that office may now be owned by a hospital system. From the outside, nothing changes. Same doctor, same waiting room, same parking lot, but on the billing side, everything changes. Because the moment a doctor's practice becomes part of a hospital network, that office is reclassified as a hospital outpatient department. And hospital outpatient departments are allowed to charge something called a facility fee on top of the normal cost of seeing the doctor. So a routine follow-up appointment that used to cost you a $30 copay now comes with an additional charge of $150, $250, sometimes $400 or more, just for walking through the same door you have always walked through. You did not receive more care. You did not see a specialist. You did not use any special equipment. The facility fee exists because the billing code changed, not because your medical experience did. For seniors on Medicare, this is particularly painful because Medicare Part B covers outpatient visits, but it covers them at a percentage. That means the patient is responsible for their share of the facility fee. And when that fee is $300 on top of the regular doctor's charge, the out-of-pocket cost for a simple blood pressure check can triple overnight. Dorothy, 74, a retired postal worker from Richmond, Virginia. She had been seeing the same cardiologist for 6 years, same office, same nurse who knew her by name. Then one quarter, her statement from Medicare showed a charge she had never seen before, a facility fee of $340 added to a routine checkup. When she called the billing department, they told her the practice had been acquired by the regional hospital system 8 months earlier. Nobody had informed her. Nobody had given her a choice. Here is what you need to know. You have the right to ask any medical office before you schedule an appointment, whether they bill as an independent practice or as a hospital outpatient department. The question is simple. Does this office charge a facility fee, and is it billed as a hospital outpatient department? If the answer is yes, you have every right to find an independent provider who performs the same service without that added charge. For routine visits, lab work, and basic imaging, the clinical care is identical. The only difference is the line item on your bill. And that line item can cost you hundreds of dollars every single visit, year after year, compounding into thousands over a retirement. Before we move on, I want to ask you something, and I am asking because your answer could genuinely help someone else watching right now who does not understand a bill they are staring at. Have you ever noticed a mysterious charge on a medical statement, something labeled a facility fee or a clinic charge that did not exist before? Did anyone explain it to you, or did it just appear? Tell me in the comments, because the more people share these stories, the harder it becomes for the system to pretend it is not happening. Trap number 4. Here is a scenario that plays out in emergency rooms and inpatient wards thousands of times a day. A senior comes in with a complaint. Maybe it is a headache that has lasted a few days. Maybe it is a sore knee after a fall. Maybe it is mild chest discomfort that turned out to be acid reflux. The initial evaluation is reasonable. A doctor listens, asks questions, does a physical exam. But then, instead of a simple diagnosis and a treatment plan, what follows is a cascade, a blood panel, then a second blood panel because one marker was slightly elevated, then an imaging scan to rule something out. then a specialist consultation triggered by the imaging scan, then a follow-up scan recommended by the specialist. Each test is individually defensible. No single order looks unreasonable on paper, but taken together, the patient has now undergone 6 or 7 billable procedures for a problem that could have been managed with 2. This is sometimes called a diagnostic cascade, and it is driven by multiple forces at once. There is the fear of malpractice, which incentivizes doctors to order every possible test so nothing is missed. There is the revenue model, because every test generates a charge. And there is the culture of modern hospital medicine, which leans heavily toward imaging and lab work over clinical judgment alone. For seniors, the financial impact is significant. Each scan, each lab draw, each specialist consultation generates its own bill. A single emergency room visit that started with a headache can produce a billing statement with 8 or 10 separate line items totaling several $1,000s. And for patients on Medicare with supplemental coverage, the copays and coinsurance on those individual items add up fast. But beyond the money, there is a medical risk that rarely gets discussed. Every unnecessary scan carries a small but real chance of finding something incidental, a shadow, a nodule, a spot that turns out to be nothing but triggers yet another round of testing and worry. In geriatric medicine, this is called overdiagnosis, and it can send a healthy 70-year-old into months of follow-up appointments, biopsies, and anxiety for a finding that was never going to cause them harm. Walter, 69, a retired high school football coach from Knoxville, Tennessee, he went to the emergency room on a Saturday evening because he felt dizzy after working in his yard in the heat. He was dehydrated. That was the diagnosis the ER physician initially suspected and ultimately confirmed. But before that confirmation came, Walter had received a CT scan of his head, a full cardiac workup, a carotid ultrasound, and a neurology consultation. His total bill before insurance was over $14,000. His out-of-pocket share came to $2,100 for dehydration. When I spoke with Walter, he told me something that stuck with me. He said, "I kept asking if all this was necessary, and they kept saying, 'We just want to be safe,' and I did not know I was allowed to say no." You are allowed to say no. And you do not have to say it combatively. You do not have to refuse care or argue with a physician. You simply have to ask the right question. Before any test or procedure is performed, say this to the ordering physician: "Is this test medically necessary for my current symptoms, or is it precautionary, and what changes in my treatment if we skip it?" That question accomplishes 2 things. First, it forces the physician to articulate a specific clinical reason for the test, which is their obligation. Second, it opens a conversation where you can participate in the decision rather than simply receiving orders. Most doctors, when asked directly and respectfully, will tell you honestly when a test is a judgment call rather than a medical imperative, and in those moments, you have the right to decline. Trap number 3. This trap catches people who actually try to advocate for themselves, which is what makes it so insidious. A senior is in a hospital bed. They have a disagreement with a treatment plan, or they want a second opinion, or they simply feel well enough to leave before the medical team is ready to discharge them. Whatever the reason, they tell a nurse or a doctor that they want to go home, and then someone says it: "If you leave now, it will be against medical advice." Those words, "against medical advice," carry enormous psychological weight. Most patients hear them and immediately picture their insurance claim being denied. They imagine Medicare refusing to pay for the hospital stay. They fear being stuck with the entire bill because they chose to leave. And so they stay, sometimes out of genuine medical need, but sometimes out of pure financial fear. They stay because they believe that 3 words on a form can void their coverage. And in many cases, that belief is wrong. Multiple studies, including research published in major medical journals, have examined whether leaving against medical advice actually leads to insurance denial. The consistent finding is that it rarely does. Medicare does not have an automatic policy of denying claims simply because a patient left against medical advice. Private insurers generally cover the services that were provided during the stay, regardless of how the stay ended. The idea that signing an AMA form wipes out your coverage is, for the vast majority of patients, a misunderstanding that has hardened into myth. But here is where the trap becomes real. The fear of that myth keeps patients from exercising their right to make decisions about their own care. And in some cases, hospital staff, not out of malice but out of habit, use the phrase "against medical advice" as a pressure tool to keep a patient compliant, even when the patient's desire to leave or to seek a second opinion is perfectly reasonable. Helen, 72, a retired dental hygienist from Albuquerque, New Mexico, she was admitted for observation after a minor cardiac arrhythmia, After 2 days, she felt fine. Her vitals had been stable for 36 hours. She wanted to go home and follow up with her own cardiologist, a doctor she trusted, someone who had managed her heart health for a decade. When she told the attending physician she was ready for discharge, the nurse came in with a form and told her she would be leaving against medical advice and that her insurance might not cover the stay. Helen was terrified. She stayed an additional night, which cost her another $1,800 in copays. When she later called Medicare to ask about the policy, the representative told her there was no automatic denial for AMA discharges and that her coverage would have applied regardless. Here is what you say if you are ever in this situation. It is calm, it is clear, and it documents your position. I understand your recommendation. I am choosing to follow up with my own physician. Please note in my chart that I am making an informed decision and not refusing emergency care. I would also like written confirmation that this does not affect my insurance coverage for services already rendered. You have the right to make medical decisions for yourself, you have the right to leave, and you have the right to do so without being financially threatened by a phrase that carries far less legal weight than most people believe. Now, if you have made it this far, do not click away, because trap number 2 is the one that takes the most money from the most people, and it is the one that almost no senior knows they can fight. The protection I am about to show you could save you or someone you love $5, $10, sometimes $50,000, and it is sitting right there in the system, waiting for someone to simply ask for it. Trap number 2. Here is something most patients do not realize. When you receive a hospital bill, the number at the bottom is not one charge. It is the sum of dozens, sometimes hundreds, of individual line items. Every medication administered, every supply used, every hour of nursing care, every consultation, every test, every bandage, every IV bag, each one is coded, priced, and added to the total. And here is the part that should make you deeply uncomfortable. Hospitals are not required to automatically send you the itemized version of that bill. What most patients receive is a summary statement. It shows the total amount, what insurance covered, and what you owe. It does not show you that you were charged $45 for a single dose of acetaminophen you could buy for pennies at a pharmacy. It does not show you that the saline IV bag was billed at $350. It does not show you the duplicate charges, the unbundled procedures, or the services that were coded at a higher complexity level than what was actually performed. Medical billing errors are not rare. They are remarkably common. Industry analyses have consistently found that a significant percentage of hospital bills contain errors, some studies suggesting the majority of bills have at least one mistake, and those errors almost never favor the patient. They favor the hospital. For seniors on Medicare with supplemental insurance, those billing errors translate directly into higher copays, higher coinsurance percentages, and higher out-of-pocket totals. You are paying your share of an inflated number, and without the itemized bill, you have no way of knowing. Frank, 73, a retired plumber from Milwaukee, Wisconsin. He had knee replacement surgery. The procedure went well. He recovered on schedule. Then the bill arrived. The summary showed a total charge of $62,000, with his out-of-pocket responsibility listed at $7,400 after Medicare, and his supplemental plan paid their portions. His daughter, who worked in accounting, asked the hospital for an itemized statement. It took 3 phone calls and 2 weeks, but when it arrived, it was 19 pages long. She went through it line by line. She found a charge for a physical therapy session that never happened. She found duplicate charges for the same blood draw on the same day. She found a surgical supply item billed at a quantity of 4 when only 1 was used. She found a room charge for a day after Frank had already been discharged. When she brought these discrepancies to the billing department with documentation, the corrected bill reduced Frank's out-of-pocket responsibility by $2,800, $2,800, sitting right there in the billing code, invisible until someone asked to see the details. Here's exactly what you do. After any hospital stay, before you pay a single dollar of your patient responsibility, you call the billing department and say these words: I am requesting a fully itemized bill with CPT codes, quantities, and dates of service for every charge. I am also requesting a billing audit to verify accuracy before I make any payment. You have the legal right to receive that itemized bill. The hospital must provide it. And once you have it, you can compare it against your own records, your discharge summary, and your memory of what actually happened during your stay. If you find discrepancies, you dispute them in writing, and you do not pay the disputed amount while the review is in process. If going through a 19-page billing statement feels overwhelming, that is understandable. There are patient advocacy organizations and medical billing advocates who will review your bill for you, often for free or for a percentage of what they save you. The key is that you asked for the document in the first place, because you cannot dispute what you cannot see. Trap number one. This is the trap that costs more seniors more money than anything else on this list. Not because they owe the money, but because they pay bills they were never actually required to pay, simply because nobody told them they had another option. Every nonprofit hospital in the United States, and the majority of hospitals in this country are nonprofit, is legally required under federal law to maintain a financial assistance program. It is sometimes called charity care. It is sometimes called a financial hardship program. The exact name varies by institution, but the requirement does not vary. If a hospital operates as a tax-exempt nonprofit entity, it must offer financial assistance to patients who qualify. And here is the part that will make you want to put your fist through a wall. The income thresholds for these programs are far higher than most people assume. You do not need to be in poverty to qualify. Many hospital financial assistance programs extend to individuals and families earning 200, 300, sometimes 400% of the federal poverty level. For a single person over 65, that can mean a household income of $60,000 or more and still qualifying for partial or even full reduction of hospital bills. Millions of seniors pay hospital bills every year that could have been reduced by 50%, 75%, or eliminated entirely under programs the hospital is legally obligated to make available. But the hospital is not required to walk up to your bed and tell you about it. They are required to have a written policy. They are required to post information about it somewhere in the building or on their website, but they are not required to sit down with every patient and explain it, which means the protection exists on paper. But in practice, unless you know to ask, you will never hear about it. You will receive a bill. You will assume you owe it. You will set up a payment plan. You will make monthly payments for months or years, and the financial assistance application will sit on the hospital's website, unfiled, because nobody told you it was there. Evelyn, 76, a retired school bus driver from Fayetteville, Arkansas. She had emergency gallbladder surgery. She was on Medicare with no supplemental insurance. Her out-of-pocket bill came to $11,200. She was living on Social Security, bringing in just over $1,900 a month. She set up a payment plan of $150 a month. She had been paying it for 5 months when her grandson, who was studying healthcare administration in college, asked her a question nobody else had thought to ask. "Grandma, did they tell you about financial assistance?" They had not. He helped her fill out the application. Based on her income, she qualified for a full write-off of her remaining balance. The hospital cleared the debt within 3 weeks of receiving the completed paperwork. She had already paid $750 that she did not owe. When she asked about a refund for those payments, she was told the policy only applied going forward. Her grandson helped her file a formal appeal. She got every dollar back. 76 years old, living on a fixed income, paying $150 a month, she should never have been billed because nobody in that hospital said 9 words to her. Would you like to apply for our financial assistance program? Here is what you say, and I want you to understand that this is not begging. This is not asking for a favor. This is accessing a program that the hospital is legally required to offer as a condition of its tax-exempt status. Before paying any hospital bill, call the billing department and say this: I am requesting an application for your hospital's financial assistance program under your charity care obligations. I would also like a copy of your written financial assistance policy and the income guidelines for eligibility. And that sentence tells the billing department 3 things. You know the program exists, you know they are required to have it, and you are requesting it formally, which means they need to respond. Do not let anyone tell you that you probably will not qualify. Do not let anyone redirect you to a payment plan before you have seen the eligibility thresholds for yourself. Fill out the application, submit it with documentation of your income, and let the program work as it was designed to. If you are denied, ask for the denial in writing with the specific income threshold that disqualified you. Compare that number against the hospital's posted policy. Financial assistance denials can be appealed, and in many cases, the appeal is successful when the patient demonstrates that the initial review was incorrect. Now, here is what I want you to do before you close this video, before you move on to the next thing, before this information settles into the back of your mind where good intentions go to disappear. Take out your phone, open your notes app, or grab a piece of paper and a pen and write down these 5 things. 1. Does this office charge a facility fee, and is it billed as a hospital outpatient department? 2. Is this test medically necessary for my current symptoms, or is it precautionary? What changes in my treatment if we skip it? 3. I am making an informed decision. Please note that in my chart, I would like written confirmation that this does not affect my insurance coverage for services already provided. 4. I am requesting a fully itemized bill with CPT codes, quantities, and dates of service. I am also requesting a billing audit before I make any payment. 5. I am requesting an application for your financial assistance program under your charity care obligations. I would like a copy of your written policy and eligibility guidelines. 5 statements. That is your hospital defense plan. Print it, photograph it, laminate it if you need to, put it in the bag you would grab if someone drove you to the emergency room at 2 in the morning. And here's my challenge to you. For the next 30 days, every time you or someone you love interacts with the medical system, a doctor visit, a specialist appointment, a hospital admission, have that list with you. Look at it before you walk in. After 30 days, it will be automatic. You will not need the list anymore because the habit will be part of how you navigate the system. The people who get hurt by these traps are not careless people. They are not uninformed people. They are people who trusted a system to be transparent with them, and the system did not hold up its end. The fix is not distrust. The fix is preparation. 5 sentences spoken clearly at the right moment by someone who knows what to ask. I have another video coming that deals with what happens after the hospital when you are transferred to a rehab center or a skilled nursing facility, because that is where an entirely new set of financial and medical traps are waiting. If you think the hospital billing system is complicated, the post-acute care system will take your breath away. Subscribe so that video reaches you when it goes live. It is the second half of this conversation, and without it, you are only protected for half the journey. Share this video with one person today, just one. A parent, a spouse, a neighbor, a friend from church, someone over 60 who might walk into a hospital next month or next year and not know any of this. That single share might be the most valuable thing you do for them this year, and they will remember that you were the one who sent it.